Glad again. Most welcome. You hear me? Got it. You hear me, Professor?
Yes.
Dikla? And hello again,
Hello.
Professor Kayahan.
Hello.
Anybody hear me?
I do hear you, yes.
I cannot hear your voice.
Hello.
Hello again. Thank you
Hi.
to join us again.
Thank you.
Thank you. Now is 12:30 and our webinar is started. Just now we have 46 participants. And if you let me and Professor Kayahan let me, can we start our program? Professor
Yes.
Kayahan?
Yes, please.
Okay. Hello, everybody, and welcome to 2 days joint online program between Tehran University of Medical Sciences Dental School and Dental Faculty of Yeditepe University in Istanbul, Turkey, with the title of Advancement in Treatment Approach with focusing on emergency cases. This program includes 4 panels, restorative prosthodontic dentistry, and or maxillofacial surgery and periodontics, which will be held in day 1. On day 2, the panels include pediatric dentistry and orthodontics and endodontics. I would like to appreciate the Dean of the Dental School of Yeditepe University, Professor Kuro, if I spell it properly, and Professor Rocht, the Dean of the School of Tehran University of Medical Sciences, helping us in organizing this program. I'm sure very useful and practical information we will deliver to you in a clear manner, and I fully expect that this webinar will influence your daily practice. The information that will be released to you in these 2 days webinar program provide you with enough information, with the opportunity to choose the right treatment approach and plan in emergency cases. As you know, the first panel starts with the restorative dentistry. In each panel, we have 4 speakers from Iran and Turkey. I would like to introduce Professor Kayahan, the professor from Yeditepe University and Restorative Department, which is moderator of this panel. And I would like to appreciate her to accompany me for holding this program. Thank you, Professor Kayahan, accompanying me in this program. The webinar on each day finishes around 5 or 6 p.m. And at the end of each webinar, each speech will be running a live question and answer, and I will ask the participant write the question in the chat box. And at the end of each panel, each speech, we have around 5-10 minutes to answer the questions. And I would like to invite you, all the participants, to attend the competition that will be held at the end of the 4th panel on day 2. For more details about this competition, please follow the chat box. All the information and details will be released in the chat box. And now the first speakers will be from Turkey, Professor Japlut. I would like to ask Professor Kayahan to introduce the speakers, and the stage is yours. Please, Professor Kayahan, the stage is yours.
Thank you, Dr. Fariba. Good morning, my colleagues, my friends, all participants and all students, and also Dr. Fariba for your nice introduction also. First of all, I would like to welcome you to this international course program, and it's also a pleasure for me to be involved in such a scientific program. You know, as you mentioned before, the first session will be about the prosthodontics and restorative dentistry, and we will have 2 speakers. Our first speaker of this session, Dr. Ceyhun Can Polat, is assistant professor in Yeditepe University, Faculty of Dentistry, Department of Prosthodontics, and the topic is prosthodontic emergencies in COVID-19 days. And if the participants have any questions or contributions, they can write on the chat box during the lecture. And after the lecture is completed, I will read and I will kindly ask your questions to our valuable speakers. And Dr. Can Polat, please.
Hello, good morning to Turkey and good afternoon to Iran. I am now trying to share my screen. My name is Ceyhun Can Polat. I have been working at the Yeditepe University School of Dentistry since 2000. And today we will be talking about prosthetic emergencies. But with the COVID-19 pandemic have been with us for more than 1.5 years, I will just remind you some precautions that we should take as we practice in our daily practice. We all have to know about the symptoms of coronavirus, and I'm sure we all know about too much about these symptoms. People with systemic diseases should be even more careful about this COVID-19 pandemic. Economic, occupational, and financial worries have led us dentists to get worried about our future. Unfortunately, we have been vaccinated, and we hope the vaccinations that we have had will work properly and we will pass through this pandemic healthily. The pre-treatment precautions that we have taken since the start of the pandemic, I will show you some slides from our faculty. As dentists, we have been trained about the viruses, but we were mostly trained, we were more careful about the viruses that were blood-borne. But this pandemic, this COVID-19 pandemic, spreads out very fastly because it's airborne. So we had to take some more precautions like barriers on the elevators and the social distancing and the appointment, the waiting rooms. It should not be very crowded. The patients should be asked to come on time so that the waiting rooms don't get very crowded. In the waiting rooms, the people should be seated apart from each other, and the newspapers and magazines have been removed already. The first thing that we have to care is first, do not harm, as Hippocrates stated. In this meaning, we have to help to stop the spread of germs. And we all know what we should do, the social distancing and wearing masks and washing hands. We are all familiar with these. Here are some changes that we have made in our students' clinic. We have separated the boxes from each other with these shields. And the precautions have been reminded to us. We have already known the precautions that we should take, but they were reminded with these signs, like when and how to wash hands, and hand hygiene and personal protective equipment, washing hands, sharp box, medical trash, and the droplet isolation, what we should do. And we also spray the clinics with sodium hypochlorous for 5 seconds and then wait for 5 minutes. We cover all touching areas with barriers. And sterilization. You see, we have been carrying out sterilization all the way, but since with this airborne COVID-19 virus, we have to be even more careful. This is a picture from the pre-pandemic times. And you see how many things we have done wrong. Now we are very careful and we dress like this as we treat patients. We also had to include a question of travel history of the patient in our dental anamnesis. Well, if we talk about the urgencies or emergencies in prosthodontics, the word emergency may not be applicable to prosthodontic treatment in the true medical sense. There are many situations in which a prosthodontic attention is required urgently. This urgent care is needed so that the patient can carry on with his usual activities without impairment in oral function or appearance. Here are a few precautions that we should take during the pandemic, like using of disposable instruments or sterilized instruments, postpone invasive dental treatment to stop generating aerosols, use of extraoral radiographs rather than intraoral ones, use of mouthwash before treatment, and use of rubber dam where applicable. The emergencies, the prosthodontic, we can classify the prosthodontic emergencies in this manner, in this classification. A fractured prosthetics, it should be repaired urgently. So you can repair it in your clinic or you can send it to the laboratory. And there are some cases where you have to do something more than repairing a denture. Like in these two cases, the patients will lose all upper teeth and they have these partial dentures. And with the pandemic, we don't want old people to come into the clinic very frequently to make new dentures, and they don't want to stay without teeth until the wound healing is completed. So in these two cases, I changed the partial dentures into complete dentures, chair side, right in the clinic, as you will see. I just covered the flange areas with pink wax, layers of pink wax, made impressions. With the pink wax layers helped me have enough space for the base plate. After the impressions have been completed, in one case, I just cut the roots off the original teeth, the natural teeth, and placed them in the impression. In the other case, I just used a temporary material to make to have the artificial teeth. Then with the help of self-curing acrylic, I placed the impressions back into the mouth. And came up with a denture like this. In this case, these are the natural teeth. Then after trimming the denture, I used a temporary relining material to place the denture in place. And this is how it looked. These are the natural teeth and these are the temporary artificial tooth with complete dentures. And here it is how it looks. A fractured, in terms of fractured prosthetics, then we go back to, we go up to the fixed ones. We may have the veneering material fractured. We can repair this with repairing kits, or we have to remove the fixed denture and send it to the laboratory. as we send it to the laboratory, we have to take some precautions, like after the impression or the material that we tried has been tested, we rinse them thoroughly, we spray them with disinfectant and wait for 5 minutes, then rinse again, put them in a plastic bag. Make sure that you don't touch the plastic bag with the gloves on the outer side. You have to take the glove off and replace the instruction sheet into the pocket. Once it gets to the laboratory, it will be rinsed thoroughly and they will keep working on. After the work has been finished at the laboratory, they will rinse it, they will spray it, put it in the plastic bag. Again, don't touch the outer side of the plastic bag with gloves. And in the clinic, we remove it, spray it, rinse it, and carry on with our treatment. If we want to remove the crowns in emergency cases, sometimes we get hard times to remove the crowns. Then we have to cut the crowns to reach to the natural tooth. In pandemic days, it might be a good idea to access the cavity created through the crown. We don't have to remove the crown so that we don't create so much aerosol. This is another emergency case where a tooth should be extracted and the patient doesn't want to leave the office, the clinic, without his tooth. What we did was to cut the crown and adhere it to the neighboring teeth as a temporary crown. And the patient was happy. Another case with 2 central incisors to be extracted. In this case, we made an impression before we extracted the teeth and sent it to the laboratory. The technician removed the teeth to be extracted and prepared 2 temporary crowns from artificial teeth. And with the help of adhesion, we placed them in place and the patient was so happy after extraction. Another method that I employ frequently is the use of the small partial denture that you make an impression before the extraction, you send it to the laboratory, the technician removes the tooth to be extracted, and with the help of small clasps, he makes a small partial denture. I strongly advise my patients to remove this appliance or denture when they are eating and when they are sleeping. But I mostly use this appliance in young ladies, and I know that they don't remove it as they have lunch at school or at work. They eat with it. And this is how it looks in mouth. The cemented crown inlay and onlays should be cemented right away. This is another emergency that we face frequently. In terms of implant-supported prosthodontics, the patient may come up with a fractured framework. Then in days of COVID-19, we can kindly smoothen the sharp edges, and we may ask the patient to keep wearing the appliance, the denture again. We don't have, it depends on the seriousness of the pandemic, whether to repair it or not. In case of loose crown screws, then we have to tighten them. Sometimes the patient who is waiting for the wound healing with a temporary abutment may lose the temporary abutment, then we have to make a small surgery and place the temporary abutment again. And what happened, the worst thing that could happen about implant-supported prosthodontics is the fracture of the screw. It happens a lot. I mostly use an explorer, a scaler, an angle drive, and some different kinds of screwdrivers that I got from a store. I put them through the sterilization before I use, and a few times I managed to remove the fractured screw with a macaron, with the help of the macaron kit from the endodontics department. What I do first is to try to turn the fractured screw counterclockwise, and in most cases, they will just come up with it. If they don't, I go with the scaler or with the angle drive, turning counterclockwise with a round burr, with a round carbide burr on it. Here are the removed, the broken, fractured screws and the removed parts. Sometimes the attachment, the female part of the attachment that has been attached to the denture may come off. And this is something that you should carry out in the clinic. You just, if you want to send it to the laboratory, you have to go through all the impression stages and stuff. It is wise to fix it into the denture right in the clinic. But you have to be very careful. You will fix it with the help of cold curing acrylic, and you have to be very careful that the cold curing acrylic doesn't flow into the undercuts. So you have to cover the undercuts. You have to fill the undercuts with the help of something like a wax. This is a utility wax from the orthodontics department. You have to cover the undercuts. Then you place the cold curing acrylic in the denture, you place it in the mouth, make sure that you keep the patient in centric relation until the cold curing acrylic gets monomerized. A fractured tooth may be treated with the help of fiber posts. Hopefully we have these fiber posts. It's easy. You just open the cavity with its own burr and then place it and adhere it to the tooth. But I just want to, you see, I don't like to use the fiber posts in other teeth than the central incisors and laterals. I know many people, many friends that they use fiber posts in canines, premolars, and molars. I just don't like to use them. In case of a canine, premolar, or molar, I like to use a cast post. And the denture caused problems can be overcome easily right in the clinic without too many sessions. Like in one session, you can remove the, you can just overcome the problem. And the adaptation of a denture before radiotherapy. This has nothing to do with COVID-19 pandemic. You have to do your best because this is emergency. A patient in need of a radiotherapy is always an emergency. So you have to take all precautions because probably the patient has been done under chemotherapy and something. So you have to be very, very, very careful, and you have to carry on the work. And you have to wash your hands. I know hand sanitizers work very well. You have to either use hand sanitizers or wash your hands regularly. And I strongly ask you and recommend you to have your staff in the clinic, the nurses, the secretary, the technician, everyone, to watch this video that is titled If Saliva Were Red, from Organization for Safety and Asepsis Procedures Foundation. It is amazing. So please have your staff see this video. And thank you for your attention. Merci behatere tavajohetun. I will be glad to answer any questions if there is any. Thank you.
Thank you for your nice presentation and excellent cases. They were very successful. I know you very well. We are working together for many years, and I saw that cases in face-to-face. I have a question. Is there any special disinfection solution for the impression materials?
Well,
or we use any type?
Yes, we have. I'm not familiar with the name, but we have a different solution for the impression materials, and we have another disinfectant solution for the surfaces. We use them separately.
Yes, they are different.
Yes.
Yes. And another question. You know, we have lots of treatment sessions in prosthodontics. And how can you manage the long-lasting prosthodontic treatments in pandemic conditions, especially for the patients with low immunity? How can we decrease the sessions?
Well, the first thing is that in case of COVID-19 days, and with such these patients, we have to, if we can postpone the treatment if we can, if it's not emergency. But if we must carry on the treatment, we have to be very careful. We have to be we don't want the patients to see each other. So we postponed the sessions. Like for a 30-minute clinical case, we make an appointment for 1 hour so that we have enough time to clean the clinic and the spraying and waiting and stuff. And with such distant sessions, the patients don't get to see each other. And since the start of the pandemic, the people have been coming to me and saying that, you see, it is surprising not to see so many people around. And I ask them, and I tell them that we have postponed the sessions to clean the clinic so that they don't see each other.
Thank you again for your answers. I'm checking additional questions, but I couldn't see. So we can continue with our second speaker of this session.
Excuse me, Professor Kayahan, I have 3 questions from Professor Jakub Palat, if you let me to ask my question.
Yes, please.
Thank you. First of all, I'm thankful for the nice presentation you had. It was very useful to me. I have some question. I would be thankful if you kindly advise me. My first question, in the first slide, you showed that, as you just mentioned, the private practice should not be overcrowded, so the patient does not see each other in order to reduce the transfer of the disease to other patients. But what about the dental faculty that each day is many patients referred and many patients are waiting in the waiting room? What is your suggestion about the controlling the pandemic in dental faculty that many patients are referred and the waiting room is overcrowded?
Well, thank you for the question. And let me give you an example from our school. Mm-hmm. The first examination that the patients go through is in the oral diagnosis department. Before the pandemic, any patient could come in at any time to have an examination. But since the start of the pandemic, we started to make appointments for the first examination in the oral diagnosis department. We don't let the patients come in as they want. They must have an appointment, so it doesn't get very crowded. And this works. And they tolerate this, they understand this. The secretaries at the front desk explained that this precaution of appointments have been taken to protect the patients from each other. So it works very well. People understand.
Okay, so by this way, the approach you have followed in these days, in these 2 years, is to limit the patient referred to dental school by calling them and give them an appointment time. Is it right?
That's right.
Okay.
Yes, it is right.
That's right. And my second question is that I think it was in the 3rd slide or 4th slide that you showed that you spray the sodium hypochlorite in the air. Is it right?
I just can't. Well, could you? Oh yeah. Well, there was something wrong with the connection. Are you asking me about the spray that we spray the whole clinic?
Yeah. What the material you meant? I think I heard that you mentioned the sodium hypochlorite is sprayed in the air.
It is called sodium hypochlorous. It is called sodium hypochlorous, not chloride. So it is used, as we have seen on TVs all around the world. We do the same thing. We spray the clinics with it for like 4 or 5 seconds is enough. Then we have to wait for another 5 minutes before entering the room.
And what interval after each patient?
Yes, in between. Okay. Yes, once the patient leaves the room, the nurse cleans everything, makes a physical cleaning. Okay? Everything is clean. Then the employee comes in and sprays the room with it. Then we wait for another 5 minutes. Then the nurse gets in to make the barriers on the touched surfaces.
And what is the concentration of the material?
I don't know. I don't want to say something wrong.
Yes. And may I ask my last question, please?
Yes, please.
Yeah, thank you. You did a great job and show you in the slide that you changed the removable partial denture to full denture by placing, extracted the tooth, separated the roots from the crowns and attached it to the removable partial denture to change it to a complete denture. And it is my question that nowadays, during this pandemic condition, is it a safe procedure for the dentist? Because the cutting of the roots and produce the huge amounts of the aerosol that might not be dangerous for the clinician. And do you suggest another treatment planning for these emergency cases in these days?
Well, if you can postpone the treatment, you should. But a patient wouldn't like to leave the clinic without teeth. In case of such a patient, like in that case, I just thought of using natural teeth in the full denture, in the complete denture. And the patient was working for a company, for a chemistry company. And after I told him that I was planning to do such a thing with natural teeth, a temporary complete denture. And he was happy with it. He agreed, and we did it. We carried on the work. And in 2 days later, he came up and said that he had to travel into Europe, and he didn't know for how long, because a competitive company was trying to steal their customers in Austria, in Romania, and in other countries. So he went to Europe. He stayed there more than 1.5 months with that denture on, and he was so happy. So the patient, if the patient doesn't want to leave the room, if he doesn't want to leave the clinic without teeth, There is nothing else to do. And as dentists, you see, I have been hearing in the news that the occupation, the members of dentistry, we are the list group that have been affected from this pandemic, because even before the pandemic, we know how to protect ourselves. We know how to wear masks. Nowadays, we are wearing 2 masks on each other. So, yeah, well, if this is kind of a must, if we have to carry on our occupation. So I wouldn't try to postpone the treatment or transferring a partial denture to a complete denture. I will do it right away in the clinic with the help of shield and everything, with the PPE, personal protective equipment and everything. Yes, I will do the same thing.
Thank you, thank you. And it was not my last question. It is my last question. The standard precautions always should be followed and should be observed. In these days and following the pandemic condition, is anything has been added to the standard precaution that you kindly show in your slide? For example, rinsing the impression under the running water and disinfecting the impression material. So all those infection control procedures that you kindly showed it in your PowerPoint and a slide is exactly the standard precaution that we previously followed and observed. Is anything has been added to this principle or not?
Yes, spraying the rooms with sodium hypochlorous has been added to these precautions, because the others have, you see, we all like social distancing. We didn't know much, to be honest, we didn't know much about social distancing. So yes, social distancing and spraying the clinics with sodium hypochlorous have been added to the precautions that we have employed earlier.
Thank you. Appreciate it. Thank you for all the details and your patience to answer my question. Best wishes for all guys and for you there, Professor. Thank you. Thank you, Professor Kayahan, that you give me the opportunity to ask my question from Professor Jakupala.
Thank you. We have another question from the participants. I recently went to a dentist and they made patients wear shoe covers before entering and they insisted on it so much. Is it really effective and necessary?
This is a good question. In the times when I had my private clinic, I was having patients wear shoe covers, yes, but I believe that, to be honest, I believe that it is to keep the clinics away from mud and rainy weathers. So I'm not sure about the microorganisms. If the staff is careful enough to take care of the clinic, it's okay if the patients didn't wear shoe covers. Well, I don't know. You see, I'm not a microbiologist or something. But in the times when I had my own clinic, yes, I had my patients wear shoe covers as they entered the clinic. I'm not sure if this is the answer, but this is all I can say.
Thank you. I think this is the answer. I also think a similar way with you. If you don't have any other question, no. So thank you very much again for your presentation and cases and the answers. Now we can continue with the second speaker of this session. Dr. Burcu Dikici is assistant professor in Yeditepe University, Faculty of Dentistry, Department of Restorative Dentistry. And the topic is restorative treatments of traumatic dental injuries. Dear doctor, please.
Thank you, Professor Kayan. Good morning, everybody, all professors, my colleagues and participants. It's very pleasure to be involved in this course and present my topic. Thank you very much. Now I am going to share my screen. My name is Dr. Burcu Dikici. Today my topic is restorative treatment of traumatic dental injuries. I have to... dental trauma is injury to the mouth, including teeth, lips, gums, tongue, and jaw bones. Soft tissue injuries to the mouth and dental trauma are typically very painful and should receive prompt treatment. 1/4 of the population under the age of 18 sustain traumatic injuries due to the sport accidents or automobile accidents, and 96% of these injuries involve maxillary incisors. Treatment procedure after the trauma affects the prognosis and diagnosis of the teeth in the mouth, and it's very essential and important. The most common dental trauma is a broken or lost tooth, and some of the tooth are lost in the future or require immediate attention for the restoration, aesthetic, and phonation. How to manage dental trauma? Clinical examination, radiographic examination, and photographic documentation is essential. We have to evaluate pulp status. Splinting time is important. The use of antibiotics if the infection is occurred, and follow-up is the management of traumatic cases. First, we have to have personal information and medical history of the patient. It is also important. Dental history is our job and very important also. The past history of the dental history of the patient determine the patient cooperation. And we have to question after the injury when, where, and how. Time is critical factor for the determination of the technique and prognosis of the treatment that we give. The shorter time between the trauma and treatment, the better prognosis. We all know this. Where, place of injury, also very important due to the prophylactic tetanus immunization. And how did the injury occur? If it occurs directly, it causes tooth fracture, root fracture. If it occurs indirectly, it may cause subcondylar fracture or temporomandibular joint dislocation. We have to question this question. Clinical examination, such as medical examination, extraoral examination, and intraoral examination are the assessment that we have to do. Medical examination, such as nasal hemorrhagia, neck pain, we have to check these questions. Extraoral examination, as we can see, if there's a fracture in the fascia or there's a fracture in the zygoma, we have to check. We have also to check these questions. And intraoral examination is again our job. Soft tissue and hard tissue examination. Soft tissue examination like laceration of tongue, hematome or bleeding in the floor, it affects our prognosis. And the hard tissue examination, type of injury, tooth fracture, tooth displacement, avulsion, color change, or the decrease in translucency. We have to check all these problems after the trauma. Radiographic examination, we should have radiography after the trauma due to the root development, root fracture, periapical radiolucency, tooth fragment, or foreign body in the soft tissue. As with all treatments, a true medical and dental history should be completed. Then extraoral and intraoral assessment should be completed next. If the emergency is due to trauma, the face or oral cavity can be cleaned with water to visualize the damaged tissue. Then, of course, radiographic examination is essential. Appropriate radiographs should be taken. If possible, tomography can be used, such as used in the serious injuries like alveolar fractures. Adjunctive diagnostic tests also important for the diagnosis and treatment for the traumatic tooth. Vitality test has to be noted that injured tooth may be in a state of shock and they won't respond. They may not respond to vitality testing. So vitality testing may be postponed 2 weeks later. These diagnostic tests determine the pulpal and periapical diagnosis, which affect the appropriate treatment that we can do. In vitality test, we should examine multiple teeth with the quadrant of concern. We have to test all the quadrants of the mouth. Testing teeth outside the area of the trauma is a baseline and provide the patient's normal response, can be a normal response to any given stimulus. And it is important to test the furthest away the teeth of the pain first, because patients will be more relaxed and less likely to provide the inaccurate results for the vitality test. Percussion is also important. Sensitivity to slight tapping may related to the periodontium injury, possible periapical pathology, root fracture or displacement, root displacement. We have to take, of course, periapical radiography.
Excuse me, Burcu, can you please talk louder?
Okay, of course.
The participants wrote on the chat box.
Okay, I can see the chat box, and I'm trying to speak louder. Thank you. The aim of the treatment of dental injuries is maintain the pulp vitality and restore normal aesthetic function, contour and occlusion. This is the aim of our treatment. Dental injuries can be classified as luxation injuries and fracture injuries. I'm going to tell all the injuries now. First, dental fractures, forces that are applied to the tooth that can lead to fracture. The classification is important because it guides the management. Class 1 fracture involves the enamel. Class 2 fracture involves the enamel and dentin. And class 3 fractures involve enamel, dentin, and the pulp tissue. Enamel fracture, or we can say chipping, is a complete fracture of enamel without the involvement of dentin and pulp. A fracture occurs when a tooth contacts a hard object with enough force to break a section of enamel. A pulp sensibility test is recommended for all the traumatic injuries because it's important to assess the pulp vitality. Treatment depends on the size of the fracture size. If we can do just contouring the enamel, or we can restore the diastema. This is my case. He broke his enamel, and I restore all the anterior region for aesthetic reason. The follow-up is also essential. 6 to 8 weeks for clinical follow-up is recommended for the enamel fracture. Enamel and dentin fracture is a complete fracture of the tooth enamel and dentin without exposure of the pulp. Sometimes pulp can exposure, we can see it. A pulp sensibility test also is recommended to confirm pulp health. Treatment depends on how to close the fracture is in relationship with the pulp. We can do provisional treatment in dentin enamel fracture, or we can do a composite restoration for the traumatized teeth. If the exposed dentin is within 0.5 millimeter of the pulp, we can use capping material. We have to follow up 6 to 8 weeks for clinical assessment. Enamel, dentin, and pulp fracture, a fracture involving enamel and dentin with exposure of the pulp. The mobility is generally normal. For young patients with immature, still developing teeth, it is advantageous to preserve pulp stability with pulp capping or partial pulpotomy. We can use calcium hydroxide or MTA material for capping. In patients with mature apical development, root canal treatment is generally recommended, but we have to try pulp capping or partial pulpotomy first, but in the follow-up weeks, we can change our treatment. But if for the clean teeth, without the caries teeth, we have to try the capping material first. Root fractures are rare fractures for among all dental injuries. They are very rare. They're defined as a fracture involves dentin, cement, and pulp because it occurs in the root. A horizontal root fracture most commonly occur in the middle third of the root and very rarely in the apical root. Maxillary central incisors are most prone to traumatic injuries due to their position in the mouth. We have to examine the proper clinical and radiographic examination for correct treatment, for correct diagnosis. In apical root fracture, there is no need the treatment is required up by X-rays up to 6 months and put tooth out of occlusion. Firstly, we have to instruct patient not to overload the tooth. 1 month later, union may occur by calcific or fibrous tissue. But if the fracture line increases in width, it is essential to do root canal treatment followed by surgical removal of apical fragments. Clinician must check the mobility of the coronal fragment and the pulp stability. It is also essential. 2 or 3 radiographs from different angulation should be taken for the management of the fracture location. It is also very important. This case is our case with Professor Tanak. 1 year follow-up of 2 maxillary central incisors with horizontal root fractures at the apical third. After the patient referred to our clinic, we applied fiber splints for all anterior incisors. And 1 month later, we have to do root canal treatment for the 2 teeth. But after 6 months, a calcific tissue formation was observed in the fracture line. During the 1 year follow-up, the picture is the 1 year follow-up and the radiography. The teeth show no mobility and excellent soft tissue healing. The oral hygiene is also important for the prognosis of the restoration. Middle root fractures, root part attached to the crown isn't enough to stabilize the tooth, so we have to splint these teeth. In general, for all the root fractures, we generally splint the teeth for mobilizing the teeth. Teeth with fractures should be splinted for 4 to 6 weeks. Why are we splint? To promote healing of periodontal ligament, neurovascular supply, and alveolar supporting. Cervical third root fracture. It is the very dangerous fracture, I think. If the fracture is at bone level, we remove the coronal fragment. Following this, the root canal treatment is done, and we can do restoration with crown or fiber post with crown. If the fracture is 1 to 2 millimeter infrabony, we have to do osteoplasty to do treatment. Then we have to do root canal treatment, or we extrude the teeth by orthodontic treatment. If the fracture is too far infrabony, we have to extract the teeth. For longitudinal fracture, the teeth is generally extracted. A requirement of successful treatment of root fracture, fragments must be immobilized in close contact and absence of infection. How the root fracture healing? By calcified tissue or connective tissue or bone and connective tissue or granulation tissue. Sometimes there is no healing if the presence of the inflammatory tissue. We always have to follow up these traumatic injuries. Now I'm going to continue with the dental trauma. Enamel infraction. It's the incomplete fracture of the enamel. Concussion is a touch or tapping. There is no displacement in the situation and does not have increased mobility. With these two traumatic injuries, we have to follow up the teeth. There is no need to do any treatment. Subluxation, an injury to the tooth, supporting tissues with abnormal loosening, but without displacement of the tooth. Exclusive luxation, displacement of the tooth out of its socket in an incisal or axial direction. Lateral luxation, displacement of the tooth in any lateral direction, usually associated with a fracture or compression of the alveolar socket wall or facial cortical bone. And intrusive luxation is a displacement of a tooth in an apical direction into the alveolar bone. Avulsion is a complete displacement of the tooth. Numerous studies show that this injury is the most serious dental injury, and the prognosis is very much dependent on the action at the place of the accident and promptly after the avulsion. The time is very important for the treatment of these injuries. The periodontal ligament is affected and the fracture of alveolar bone may occur. Replantation is in most situations the treatment of choice, but cannot always be carried out immediately. As soon as possible, we have to reimplant the avulsed permanent teeth. It's also very rare among all the dental injuries. And appropriate emergency management of treatment plans are important. As I say, replantation is the most situation, is the treatment option, but cannot always carry it out immediately. There are also individual situations when replantation is not indicated in severe caries or periodontal disease, non-cooperating patients, severe medical condition, which must be dealt with individually. But sometimes replantation may successfully save the tooth, but it is important to realize that some of the reimplanted teeth have lower chance for long-term survival. So in the future, it can be expected in the later stage. This time is very important for evolution. Subluxation, as I mentioned, injury of periodontium without displacement and with slight mobility. It can be pain, mobility, but no displacement. We have to stabilize the tooth in the dental subluxation. There is no need to treatment, but we have to follow up these injuries. Splint is not recommended more than 2 weeks. It is important also. Lateral luxation, the tooth is displaced laterally. In general, the tooth is mobile and tender to touch. On percussion, the metallic sound, we can feel the metallic sound, and vitality test should be done. In the subluxation traumatic injuries, repositioning is recommended as soon as possible with fingers or forceps, and splinting for 3 to 4 weeks and may require additional weeks if associated with marginal bone fracture. This is also very important and dangerous traumatic injuries. Splinting stabilization periods differ from each other. For subluxation, 2 weeks. For intrusion and extrusion and lateral luxation, 4 weeks. And for root fracture, 6 to 8 weeks, we can splint the teeth. For evolution and reimplantation, for open apex, 2 to 4 weeks. For closed apex, 1 week is recommended for dental traumatology for the last update. This is also our case with my head of the department of my professor, Esra Can, a multidisciplinary approach for the restoration of a root crown fracture with the involvement of crestal attached tissue. It's a 14-year follow-up case. A 30-year-old patient was referred to our clinic due to the car accident, and there's a crack in the incisors, maxillary incisors. Following local anesthesia, we removed the coronal segment of the patient, and we have to do periodontal treatment. They length the root fragment. They length the distance between the fracture line and the alveolar bone up to 3 millimeters, I think. Then they close the periodontal tissue. Then we attach the tooth with microhybrid composite. After the 14 years, revealed favorable functional and aesthetic outcomes, biomimetic characteristics of anterior teeth. The first treatment option for the rehabilitation of a crown fracture should be reattachment, because it is still following the trauma, is relatively intact and adapts very well to the remaining tooth. They are conservative and effective alternative treatment for various restorative treatments, and it's also cost effective. It has a lot of advantages. This is another case of our long-term provisional aesthetic restoration extracted tooth, crown, and fiber reinforced composite in conjunction with extraoral intracorneal bleaching. This is a 22-year-old woman with pain and discoloration complaint at the right maxillary incisor. The tooth decided to extract it due to the apical resorption, due to the trauma of the teeth, lower teeth. I'm very sorry. We extracted the tooth, and then following intraoral and radiographic examination, we place the extracted tooth after the bleaching. We use the plan to use Pontic as a bleaching procedure with the extracted tooth. 1 year evaluation of the case, it reveals the approach is very feasible and durable treatment for the aesthetic quality of the severely discolored and traumatized teeth. This is the permanent dentition follow-up regime. I already talked about this situation. Now I want to talk about guidelines for dental care provision during the COVID-19 pandemic. Now we are in a pandemic situation, and it's very difficult for us to examine the patient with trauma. They categorize the treatment. They categorize it to 5 parts for the treatment. When the unconfirmed case refer to our clinic, we can do emergency management of light treatment conditions. We can do urgent conditions that can be managed with minimally invasive procedures without aerosol generation, or we can do minimally invasive treatment with aerosol generating procedures. But in the COVID-19 confirmed cases in traumatic injuries, especially in active disease, if unstable patient for, we have only just do emergency management of life-threatening conditions. If the patient is stable, we can, of course, do the emergency management of life-threatening conditions, or we can do urgent conditions that can be managed with minimally invasive procedures without aerosol generation. For the treatment, intraoral imaging or radiograph should be reduced due to the salivation. And we have to use provide an iodine mouthwash for the at least 40 seconds before the procedure to reduce the viral load in the patient's saliva in the COVID-19 patient and with trauma, refer to our clinic trauma. We all have to disposable and single-use instruments whenever possible to reduce the cross infection, of course. Rubber dam, we have to use rubber dam with the patient. Dental treatment should be as minimally as invasive, and with not to use aerosol generating procedures. We have to avoid this procedure. We have to do emergency management. What are the dental treatment categories? They categorize the emergency situation. For A, emergency is an unstable maxillofacial fractures that can compromise the patient's airway. B, urgent condition that can be managed without aerosol generation. A severe pain from fractured vital tooth that can be managed without aerosol generation. Dental trauma with avulsion, luxation that can be minimally managed without aerosol generation. And stable maxillofacial fracture that requires no intervention. And C, urgent condition need to manage with invasive or aerosol generating procedures is the dental trauma with avulsion, luxation that needs invasive aerosol generating procedures. These are, of course, the restorative treatment. And this is the final of my presentation. Thank you for your kind attention.
Dr. Burcu Dikici, thank you for your excellent presentation with a comprehensive review and the successful cases also. As we all know, dental trauma is one of the most challenging cases in dentistry, and the treatment has a multidisciplinary approach. So it's very important to decide the problem, the diagnose, to decide the treatment plan in the alternative solutions, and to organize all the procedures within the different departments. So thank you very much for your presentation. But we have some questions also, both from the participants, and I will have a few questions. The first one is electrodontometry vitality test commonly used in daily practice?
Yes, of course. We can use electrodiometry for the vitality test. Mm-hmm. If we don't have, we can use Pulp test. It is also very comfortable for the patients and for the dentist. You can use it, but we have to do vitality test for all the traumatic injuries because we can't have the right answers before the traumatized teeth.
And can you please tell which you use firstly?
We generally use
vitality test, they ask.
We generally use cold test
first
in our faculty.
Mm-hmm. Okay. And the second question, why do you prefer natural tooth as a pontic in fiber treatment?
Yes, natural tooth in our case, we used it in general, we use natural tooth because it has advantages over the composites and porcelain restoration. First, bonding to fiber with natural tooth is better, and they give us a better aesthetics due to the appearance of the natural tooth. And they have similar wear resistance. They have similar color change with the adjacent tooth. Besides this, they are minimally invasive and biomimetic treatments. They are cost effective. So we prefer to use natural tooth for the fibers.
Maybe the adhesion would be better also.
Yes, of course.
And another question, why do we have different splinting time for trauma?
Different splinting time. Actually, the answer hasn't been found regarding the duration of the splinting time. In general, we should assess the clinical aspect for the splinting time. For the effect of the duration of the immobilization is changed for the patients for the diagnosis of the traumatic injuries. The long-term splint leads to ankylose or replacement of the restoration. But better outcome of the healing of the case is the short-term use of the splint. But as I mentioned, it is better to use fiber splint according to the clinical case.
Depends, I think. Okay. Do you have any additional questions from the moderators, speakers?
Hello again. And thank you, Professor, for your absolutely fine presentation. It was very useful to make the traumatic lesions is one of the most prevalent conditions that appears in my country, in your country, and everywhere. And a very good point you mentioned to that. I appreciate that. I have 3 questions. If you kindly advise me on what should I do. In COVID-19 condition, as you mentioned, the treatment approach should be as much as conservative and avoiding producing aerosol and droplets and particles. But what we can do with the patient referred to us with the tooth that has been evolved and has received a trauma with subluxation and luxations, what is your recommendation? Do we need to do the absolute treatment for this patient, for example, an avulsed tooth? If we miss the time, so we miss all the things with that patient. We should do something. It does not depend on the pandemic condition. What is your recommendation?
In pandemic situation, we have to do only emergency management for life-threatening conditions. But if there's a relaxation, avulsion, some emergency cases, we have to do the right treatment.
Mm-hmm. Mm-hmm. Okay, and I think you mentioned a type of mouthwash. Yes, sorry, and that you prescribed to your patients before the treatment. What was that mouthwash?
It is Providine. Providine iodine.
Corridor iodine. Thank you for that. And another thing, the last slide of yours before the last session, the last slide was a table that present the type of trauma and the treatment that should be done for in emergency cases and COVID-19 condition. Would you share it later with us, because the font was so small I could not read it properly. Can you at least let us know what is the reference that we can write it down and refer to that reference book and read it properly? Would you please write in the chat box and introduce the reference book?
Sure, I can send you and share with you.
Thank you.
I just talk about the restorative part of the emergency cases in trauma. It has all the departments for COVID-19 procedures.
Yeah,
I can share with you, of course.
Thank you. Appreciate that. Best wishes for you.
Thank you very much.
Thank you. Professor Kayahan, I'm really thankful to you and all the speakers from Turkey. I really enjoyed it. They had absolutely great speech and presentation. It was very useful to me personally. I'm sure that it was useful for all the participants and audience.
Thank you. Now we are at the end of the first session, and I would also thank you to organizing committee, all the speakers, moderators, all the participants. I hope to see you in the future organization together again.
Sure, not in the virtual condition, face to face in Tehran and in Turkey. I hope so. That this happens in near future and very soon.
Thank you.
Thank you. Now the first speakers would be from TOMS, Tehran University of Medical Science. The first speaker is Dr. Behnia Far from Restorative Dentistry Department. She's the assistant professor in dental faculty of Restorative Dentistry Department. Dr. Behnia Far, please. The stage is yours. We cannot hear your voice. Would you please turn on your microphone? Okay, it's fine. Would you please share a screen?
Hello.
Hello. Good time to you and everybody. Yes, we can see your PowerPoint and slide.
Hello to everyone, to all of my colleagues, to the professors and all of the students. Today I'm talking about pulp protection using cavity liners and bases. I'm Dr. Behnaz Behniyafar, assistant professor at Tehran University of Medical Sciences, International Campus and Restorative Dentistry Department. It's my pleasure to be in your session. I have prepared 2 questions for the students, which are, I will read on it. I want you to pay attention to my speech and then trying to answer to it. The first question is, which of the following condition is indicated for pulp capping treatment. A, vital tooth with spontaneous pain, long pain on stimulation, pre-apical radiograph with apical radiolucency, macro exposures while caries removal, mechanical micro exposures. And the second question is, what is the most important factor in protecting the pulp? A, type of the restorative material, type of selected liners, C, antibacterial effect of the restorative material or cavity liners, D, remaining dentin thickness, and E, thermal protection of the pulp either by the restorative materials or cavity liners. As we know, the RDT, or the remaining dentin thickness, is the single and the most important factor in protecting the pulp. In vitro studies reveal that when we have 0.5 millimeters of remaining dentin thickness, it will reduce the effect of toxic substances by 75%. Whenever the thickness increases, this reduction increases. When it's 1 millimeter thickness, it's 90%. And when we have 2 millimeter thickness of RDT, there is little or no pulpal reaction. This is very, very important for the insulation factor beneath the restorative cavity and the pulp. Nowadays, dental restorative materials have been developed to provide pulpal protection and prevent the pulpal reaction. These are two very important jobs that they do. I want to speak about 3 materials that are used under the restorative materials for protecting the pulp. First of all, the sealers, second liners, and 3, the bases. The sealers provide a seamless transition from restoration to the tooth structure. The liners are placed with a minimal thickness, less than 0.5 millimeters, that provide therapeutic benefits, like antibacterial action that promotes pulpal health. The bases are also used as dentin replacement materials. They have many actions like thermal insulation, fluoride relief, and dental seal-through adhesion. As we know, we have the LCTE degree. What is it? It's the change in length by unit length or degree centigrade change in temperature. As you see in this table, we have some of the degrees for materials. The tooth structure has 9 to 11 degree. That the material like glass ionomers have the degrees near to tooth structure. But other dental materials like dental amalgams and composites have a most far, they have more far degree from the tooth structure. So what happens if we have changes in the LCTE? What occurs? It occurs the percolation. Percolation is the movement of fluids through porous materials, as in the cyclic ingress and egress of fluids at the restoration margin. When we have cooling, we have the contraction in the tooth structure and the dental materials. So we have the ingress of the fluids. And when we have heat, we have the expansion. So the fluids are expressed and there is egress. You can see the gaps between the dental material and the tooth over here. You see how the fluids can egress and egress between these two materials. So if we have interfacial gap between the tooth and the restoration, it may allow microleakage to occur. What causes? It causes marginal discoloration, secondary caries, and pulpal pathology. As you see in these pictures, you can see the discoloration and the fractures that occurred between the material and the tooth structure. The first materials, the category of materials, are cavity sealers. They have 3 subgroups. First, the varnishes, second, the bonding agents, and 3, third, the dentin desensitizers. The very first cavity sealers were varnishes. They were used on cut tooth surfaces, and they were used for decades to fill the gap between amalgam and the tooth until the corrosion from amalgam is formed. Nowadays, some practitioners use it, but it's mostly declined. The thin layer is 2 to 5 micrometers. The varnishes reduce the penetration of bacteria and their byproducts into dentinal tubules, but they don't provide any thermal insulation. The dry solution of varnishes contains natural gum as copal plus rosin, which is synthetic resin in dissolved in organic solvent like acetone, chloroform, and ether. The second subgroups are enamel and dentin bondings. What do the bondings do? The bondings provide retention and they prevent leakage around enamel of the restorations because the monomers polymerize and interlock. Bonding to enamel is a relatively simple process without major technical requirements or difficulty. The etching process increases the surface energy. The bonding to dentin presents much greater challenge. Dentin adhesion relies primarily on the penetration of adhesive monomers into the network of collagen fibers. So the bondings provide retention and they prevent the leakage around the margins of enamel and dentin because they polymerize and interlock into the dentin. Amalgam bondings are another generation of bondings. As we know, amalgam is a hydrophobic material. Dentin is hydrophile. So they need a wetting agent between them. What is the key wetting primer? It's Formetta. It decreases the leakage of fluids when compared to non-coated or varnish-coated amalgam cavity walls. Clinical studies show that no evidence of reduced post-operative sensitivity has been seen, and there is no retention for amalgam restorations. The third subgroup is desensitizer agents. Pluma is the most important one. It has 5% glutaraldehyd and 35% HEMA. It occludes the dental tubules by precipitation of plasma proteins and limits the potential for tubular fluid movement and resultant sensitivity. As you see, there's a pack of Pluma, and the precipitation of Pluma in the dentinal tubules. The second lines are cavity liners. Cavity liners are used to medicate the pulp. They stimulate the reparative dentin formation, and their thickness should be under 0.5 millimeters. They can adhere to tooth structure, which in the form of the light cures. They can be antibacterial in promoting pulpal health because they consist of calcium hydroxide. One of the trading marks are Dicol from Dentsply Company, which consists of calcium hydroxide. If the excavation extends into or within 0.5 millimeters of the pulp, a calcium hydroxide liner usually is selected to stimulate the reparative dentin. You see over here, one of the self-cure ones and one of the light cure ones of the calcium hydroxide. This is a Dicol pen for mixing the accelerator and the activator and putting in the purpose origin. The basic pH stimulates reparative dentin formation. We should know that we should make sure that the surface of the tooth is relatively dry. We can put the dical sparingly on the surface we need. We shouldn't put it over it, and because the compressive strength of the dical is very low, and it only has the medical action. They are used in the deepest part of the preparation, which there is under 0.5 millimeters of RDT. Calcium hydroxide raises the pH of the oral environment, and recent studies show that the calcium hydroxide stimulates the remineralization through solubilization of non-collagenous proteins like TGF-beta1 and GAGs, which include the growth factors. As we know, the bacteria grows in an acidic environment. High concentrations of calcium hydroxide with pH over 11 are toxic. So there's a question, what does the calcium hydroxide do after exposing to the pulpal tissue? First of all, we have the necrosis to a depth of 1 millimeter or more. Because it has the high pH, it helps to coagulate hemorrhagic exodus of the superficial pulp. The second is neutrophils infiltrate to the necrotic zone. The third is that within 5 to 8 weeks to months, we have light inflammation response. And 4, after weeks to months, the necrotic zone undergoes dystrophic calcification, which appears to be a stimulus for dentin bridge formation. Traditional calcium hydroxide were chemical autocure setting reaction. What are the problems that we have with dicals? Traditionals may continue to dissolve over time due to microleakage or dental fluids present. They lose as much as 10 to 30% of their original volume. The light cure ones have overcome some of these weaknesses, but they don't have the effective benefits as chemical autocured ones. Other materials are MTA, mineral trioxide aggregates. They have very slow setting, about 3 hours. Their compressive strength is very low. They have difficult handling because the setting time is 3 hours. Technique sensitive, they are very technique sensitive in definitive restorations due to slow setting, as I said. They are mostly used as DPCs. Most of the actions of the MTA is like calcium hydroxide. It is antibacterial. It has biocompatibility, high pH, radiopacity, releasing bioactive dentin matrix proteins. But they seal very better than the calcium hydroxides. They form a thick and more uniform dental bridge, and they have less inflammatory response. Also, they have less necrosis of pulpal tissues. Another material is biodentin. It has powder and liquid. The powder consists of tricalcium silicate, calcium carbonate, zirconium oxide as a radiopacifier. The liquid contains calcium chloride solution containing modified polycarboxylate instead of water. They have short setting times, 10 to 12 minutes. The efficacy is similar to MTA in DPCs. They form a complete dentinal bridge. There is no inflammatory pulpal response, and the odontoblasts are well arranged, and odontoblast-like cells were observed after 6 weeks. The third line are cavity bases. The thickness that cavity bases are used are about 0.5 to 1.5 millimeters. They are mostly glass ionomers. They have initial electrical insulation, they have some thermal protection and may provide fluoride release. We have two types of glass ionomers, the conventionals and the light Q ones. The light Q ones are resin-modified glass ionomer, or as known RMGI. The characteristics of glass ionomers are fluoride release, anti-karyogenicity. The mechanism is they have initial low pH and they have chemical bond and they can release fluoride. Because they have adhesion to enamel and dentin, this reduces the microleakage and also the physical exclusions. As you see in this picture, there's a glass ionomer, which is based on acid and base reaction of silicate glass powder. They have calcium aluminum silicate and aqueous polyalkylic acid, which is unsaturated carboxylic acid, and an ionomer. Resin-modified glass ionomer has both acid and base reaction as well as polymerization reaction. It has stronger bond to dentin than glass ionomer due to mechanical interlocking of polymer in dentin. One of the examples of RMGI is Fuji lining LC from GC. Okay. We should place a glass ionomer over a dicol or calcium hydroxide. Why should we do this? First of all, because the compressive strength of dicol is very poor, and the glass ionomer will seal the margins around the dicol. As we said, the cavity faces have thermal insulation. It is very important, as I said in the first slide, that we should have 2 millimeters of dentin or an equivalent thickness of restorative material that should exist to protect the pulp. About 1 to 1.5 millimeters is acceptable. Thermal insulation has been found to be directly proportional to the thickness of the insulating material and the structure of the material. Other cavity bases that are used are zinc oxide ogenol and zinc phosphate cements that were very popular bases in the past, but their use has been declined. The bases with ogenol can inhibit polymerization of resin composite. So we shouldn't use the ogenol formulation underneath the dentin bonding system or composites. We should not remove the sound tooth structure to provide space for a base, because when the amount of a base material increases, the bulk of the restorative material is decreased and it may lead to fracture of the restoration, as you see in this picture. Okay, when we want to do the direct and indirect pulp cap procedures, which conditions are favorable for selecting these items? First of all, the tooth must be vital with no history of spontaneous pain. Second, the pain elicited during pulp testing or hot or cold thermal tests should not linger after stimulus removal. Third, the preapical radiograph should show no evidence of preapical lesions and when we have mechanical microexposures. As you see in this picture, the practitioner has removed all of the caries, and we can't see any caries in this cavity. During the cavity preparation and removing the caries, there's a microscope exposure that it can be lined with calcium hydroxide and liners, and then the base should be covered on it to make 2 millimeters thickness of the remaining dental thickness that should be over there. Over here, it's a schematic view. As you see in the first patient, this patient has constant pain, so the tooth must be necrotic and needs the RCT. Patients number 2 and 3, they have pain on stimulation, long duration lasting, which is longer than 15 seconds after removal stimulus. They have irreversible pulpitis. They need RCT too, but in patient number 4, the pain on stimulation is short, has short duration, which is 10 to 15 seconds upon stimulus removal. This could be reversible pulpitis and could be, the tooth could be saved by pulp capping methods. As we know, the indirect pulp cap therapy is preferred over direct pulp cap. We should monitor the pulpal health for several months. It's very important. And also, we should seal the cavity very well with restorative materials. It is not recommended to leave carious material if the teeth are to be crowned or serve as abutments for fixed partial dentures or removable partial dentures. In the procedure of indirect pulp cap, the deep carious lesion with no spontaneous pain and vitality tastes are normal. This is an attempt to maintain pulpal vitality by placing a material over a small amount of remaining infected dentin. Removal of these caries may result in a pulpal exposure. What should we do in IPC? We can remove the wet, soft, infected dentin which is near the DEJ. The DEJ should be very clean. We should not remove caries close to the pulp, which are dry, fibrous demineralized dentin. And then we can put the RMGI or glass ionomer over it to the thickness which is favorable. And the last, we should restore the tooth with definitive procedures. We should place a well-sealed restoration. Remaining bacteria over the place is isolated, preventing acid formation and arresting the caries process. Shows that, so that is very good procedure for saving the tooth vital. Several studies show that restored tooth with partial caries removal have equal success compared with teeth with complete caries removal. Studies show that indirect pulp capping after 4 to 12 months have lesions that their color has changed from light brown to dark brown. The tissue consistency has changed from soft and wet to hard and dry. Streptococcus mutans and lactobacillus have been reduced to few or zero, and X-rays show minor changes or decrease in radiolucent zone. In DPC, there's another procedure. It's an attempt to maintain pulpal vitality by placing a material directly over the exposed pulp. We have small, which is mechanical and non-carious exposure. It's very important in a healthy pulp. The field must be isolated with a dental dam. We should achieve hemostasis, and we should rinse the place with normal saline. The calcium hydroxide is the golden standard material that is that comes over the place. And then we should place a base like Fuji lining and a well-sealed final temporary restorations over the exposed pulp. As you see in this picture, we have tertiary dentin that has been stimulated and the exposure is now over. In this picture, we have caries, which is very near to the pulpal horn. Care should be taken when we want to have the caries removal. And in this picture, in this molar, we have extensive caries. After caries removal, which is very near to pulp, we put the dical or calcium hydroxide over the place, only over the place which we know that the pulp is over there, and then seal it with glass ionomer over it. And the next stage is restore the tooth very well, which is carefully sealed. Thank you for your attention. And my speech is over.
Thank you, Dr. Behniafer, for your nice presentations about the protection of the pulpal tissue during the caries of mechanical exposure. That's is very useful during the treatment procedure in the restorative dentistry. I have some question. I will be thankful if you or Professor Kayahan help me and advise me what should I do. I wanted to ask one question. I talked about it previously, but one question appeared in my, not one question, three questions appeared in my mind. According to your presentation, one of the material that nowadays, not nowadays, there's several years, that is has been recommended to be used instead of calcium hydroxide paste is mineral tyroxide aggregates or biodentin. For my question is about mineral tyroxide aggregates, MTA. Then as you mentioned, it has a long setting time. If I want to finish the treatment session in one appointment, especially nowadays in COVID pandemic condition, I cannot wait for its complete setting and place a temporary restorative material over it and ask the patients for another appointment to come back and remove the temporary restoration and fill it again. Do you recommend to cover the MTA with a resin modified glass ionomer and restore the tooth at the same appointment? Because always the concern is about the competition of water between MTA and the covering glass ionomer that might prevent the complete setting of MTA. But if I think, and I read in several articles, if I use resin modified glass ionomer instead of glass ionomer, conventional glass type of conventional glass ionomer, this competition of water between the MTA and glass ionomer will be reduced, and so I can finish the restoration at the same time. Do you recommend it to do it for covering the exposure sites or mechanical or caries exposure and finish the restorative treatment at the same session?
Well, most studies reveal that when we put the MTA over the place, it's better that we have temporary restorations over it because of the setting time. But we can use some materials that consist of calcium hydroxide and have setting times lower than MTA, which is like biodentin. We can use that, which is 10 to 12 minutes.
Okay. And Dr. Kayahan, do you have any recommendation about the question I had in your practice? Do you cover MTA with glass ionomer and do finalize the treatment, the restorative treatment of the tooth at the same appointment?
Thank you. I don't make any procedure directly in the clinic. So I send my patients to restorative department. So
Okay.
I have a question to the speaker, if it's possible. What's
so just please let me know.
Yeah.
Sorry, please let me know in the professor in the restorative department and your faculty what they do. Do you know that?
No, I'm not
About
sure.
The question? No. Okay. Thank
My
you.
question is, how do you make the fiber post restoration with the MTA restorated tooth? Do you have
fiber post restoration in the vital tooth?
No, in MTA restorated tooth.
So do you mean that tooth that has received the cavity liner MTA?
Yeah. No. In endodontically treated teeth with MTA restoration.
A tooth that has received endodontic treatment.
Yeah. Do you have for example, any different procedure with the fiber post restorations? So
if we have used MTA and endodontic tooth that has been received endodontic treatment, probably there was a root resorption that we need apical closure, and the MTA has been used. So the apical plug, the MTA plug has been placed just in the 3 or 5 apical portion of the tooth. So the remaining part of the root canal is free, just or filled with gutta percha. So it depends on how much tooth structure has remained. Do we need a post or not? If we need a post, then we need to remove the gutta percha. But the question, there should be a question in our mind that whether the gutta percha remain around 3 to 4 millimeter at the apical end of part of the root. If it does not, if no gutta percha remains in the apical part of the root, so we should change our treatment planning.
And I'm trying to ask, especially with the lateral wall perforations, not the apical closing, but.
So about the wall, if it is a wall perforation, the endodontist probably provide a pass for the restorative dentistry to place it in the safe procedure if a fiber post is absolutely required. But if there is an exposure in the root wall, we try to avoid touching and invading the root canal as much as possible. But if we have to do it, we will ask the endodontist at the same time that the restorative dentists work together to cooperate with each other to provide a pass that without touching the MTA in the cavity wall that has been perforated, the fiber post is used. But as much as I know, if any exposure has occurred, we try to avoid invading the canal again. We should change the treatment planning. So, for example, using onlay or endocrown, you do not use a post, any type of post. It could be casting post, it could be fiber post. So I will try to use the tooth structure in the coronal portion as much as possible and using the adhesive procedure to avoid invading the root canal anymore. I don't know.
You prefer the changing the indications, or maybe you avoid to use that route? Maybe you can.
If there is any tooth structure remains in the coronal portion, I try to use that coronal portion and use the adhesive techniques to avoid invading the root canal anymore.
But just in case, if you have to, do you make that procedure on the same time or you wait? On the same time, MTA application, or
it depends. It depends, as you know. It depends on the MTA. If the setting time of MTA, it takes a long time, so we have to wait until the setting time is finished. But if the MTA has short setting time, for example, if somebody used biodentin, so we can start our procedure sooner. But in my personally, even for biodentin, because I have practice with biodentin, even the manufacturer has claimed that it's set in 10 to 12 minutes. It does not set completely. So I prefer to defer the appointment for the next session.
Okay, thank you. We make similar procedure. I just want to learn.
Do you do the same procedure?
Yes,
okay, similar. So we are neighbors, so we have the same kind of opinion.
Thank you.
Thank you for your question that make it clear for me. So I had some another question. I finish it. Dr. Behniafer, you recommend for cavity sealer the bonding, adhesive bonding. It is my questions. If you use adhesive bonding, for example, selfish adhesive, for example, one of the products could be Clearfield SE bond from the Curary, a product of the Curary manufacturer. If we apply it instead of varnish to occlude the tubules to prevent the sensitivity, the bonding practice and works the same as varnish. So because it will be solved in the long term and the leakage again occurs, what is your recommendation? Do you recommend after application of the adhesive agents, we remove the bonding from the enamel margin very gently with a bare? What is your recommendation?
Excuse me, you are asking about restoring with amalgam or resin composite?
No. You about the cavity sealers that we have to occlude the tubules that previously was done with varnish and nowadays with different type of bonding agents that can be selfish adhesive. That could be two bottles like Clearfield SE bond from the product of the Curary company. The bonding agent will remain on the enamel margins. So if I have placed, for example, amalgam restorations in my country, because amalgam has remained still in my country. So the gap will remain between the amalgam and the tooth structure, and the bonding agent has remained between this interface. So it will practice the same as varnish. What should I do? Do you recommend to remove the bonding agent in the enamel margin with the bare very gently or not?
Well, I recommend that you use these varnishes. If you are speaking about varnishes, because I didn't understand very well, but if you use the varnishes, it's better to use on the dentin surfaces, I think.
Do you still use varnish nowadays?
No. You're speaking about varnish or bonding?
Bonding agent. I talk about bonding agent. What we should do that to avoid the leakage.
Revealed that we should cover it up. No, we can leave it over there. I don't know. What's your suggestion?
If I use a bonding agent to seal the cavities, to occlude the tubules, at the end, after light curing, I remove the bonding agent from the peripheral margins in the enamel margins. If I want to restore the tooth with amalgam restoration after occluding the tubules, with a bare very gently to remove that bonding agent.
Very gentle, because maybe the enamel is beveled.
Enamel is?
Maybe the enamel is it goes through the burr.
Yes, but very gently. Not very gently. Just remove. Thank you. I appreciate that.
Thank you very much.
Thank you, Professor Kayahan, to let me know what is the treatment procedure and the treatment approach in Turkey. So I learned from you. If you have any other question, please let me know. Then I can learn more from you.
No, thank you.
I appreciate it. Thank you for all your kindness. So the next speaker is thank you, Dr. Behniafer, for presentation. I appreciate that. Best wishes for you. Is there any question from the speakers, from the participant? No question? Okay. We go to the next speaker and the last speaker in this panel, Restorative Prosthodontic Department. That will be presented by Dr. Farid. Dr. Farid, please turn on your video and microphone. Dr. Farid is Assistant Professor of the Department of Prosthodontic Dentistry. Would you please turn on your microphone and video? Dr. Farid, do you hear me? Hello?
Yes, hello. Sorry.
Hello, I cannot see you. Okay,
no.
Now I can see you. Yes, that's right. Thank you. Hello, Dr. Farid.
Hello to you and other.
Thank you to joining us.
Okay, yeah, thank you. And now we have to go for the slides.
Would you please share your screen?
Yeah, now, is it okay right now?
I cannot see your, yes. I can see it. In the name of God, it's the first slide.
Yeah,
okay.
That's it.
Thank you.
Thank you. And thank our colleagues from Yeditepe University, and lectures were very informative for me, and I think for the others. And so without any other speak, I start my presentation. What I'm going to talk about is dental prosthetic emergencies and how new technologies help us to handle them, to manage them. As a very nice Dr. Kanaplat told, I'm sorry if I'm not saying correctly. There is something that you can do in your office, but sometimes you can do with the new technologies. We were asked to have questions for the audiences. So I have made 2 questions, and I think that you can answer it correctly, easily. The questions are: which prosthetic emergency can completely be managed by CAD/CAM technology? The first answer is making a new crown. The second, rebasing a complete denture. Third is increasing the retention of a partial denture, removing a fractured implant screw, repairing a chipped veneering layer. And, the second question is, in which removable cases can final impressions be taken by intraoral scanners? The first answer is complete denture. The second is Kennedy class 1 removable partial dentures. The third answer is Kennedy class 2 removable partial dentures. The next is Kennedy class 3 removable partial dentures. And the last answer is all of the above. Let's, from the beginning, we make 2 groups of patients who urgently seeks treatment. The first group is the patient who doesn't have any prosthetic treatment at the location of interest, and they may need natural tooth supported prosthesis or implant supported prosthesis. The second group is the patients who already have a prosthesis, and they now there is a problem with it. The prosthesis may be tooth supported or implant supported. Of course, it goes without saying that the second group are more sophisticated, complicated the treatment of the second group. Now, by the new technology in restorative dentistry, we mainly mean CAD/CAM technology. Of course, we have other technologies like CBCTs that can help us, but what I'm going to talk about is CAD/CAM. The first step in using CAD/CAM technology is data acquisition or data collecting. It means we have an optic impression of intraoral structures like teeth and adjacent tissues. It could be intraoral scanning or extraoral scanning. Extraoral scannings are done on the casts or impression taken from the mouth. The next step is designing our intended prosthesis and then making it. Making could be in the form of subtractive, that is milling, or additive, that is 3D printing. Milling machines in the CAD/CAM technology that we use in dentistry are two different milling machines we have in dentistry. One of them is in-office or chairside one. The other one is the laboratory milling machines. The chairside one can be used for making simple restorations like inlays, onlays, or crowns, single crowns, and short span bridges. But the lab scanners can be, lab milling machines can be used for milling metals even. And with right software, they can be used for milling the denture bases. The steps of prosthetic treatment is the same regardless of what technology you are using. Is it a removable prosthesis or fixed prosthesis? Is it implant supported or tooth supported? Everything begins by a thorough examination. You should examine intraoral structures. You should also pay attention to the extraoral structures, and then radiographs and occlusal checking. Then you should make the diagnosis and then the treatment planning. How the new technology can help us if you have an intraoral scanner, or even if you send the cast to the lab. Intraoral scanners, of course, better serve this purpose. You can have the data of patient mouth before or after treatment forever. It means that, you know, we can't keep the cast of the patient for the long time, forever. But these data, because they take a very small space of your computer, you can keep them forever. And if you want to communicate with your patient, if you want to discuss with the patient about the treatment planning, you can use them. Also, you can see the occlusion from the lingual side, and you can talk about the heavy occlusal contacts, where are then premature contacts or interferences. Then we have intraoral procedures that routinely we do it. And then we have lab procedures. Laboratory procedures actually are very helped by new technologies. It means that new technology like CAD/CAM has made these procedures faster and easier with less steps. So the new technology mostly helps lab procedures rather than intraoral procedures. Then we have let's talk about complete denture, and when new technologies can help us in making a complete denture. Actually, new technology helps us after border molding and final impression. Why? Because at the time being, no intraoral scanner can do border molding for us. So for the complete denture, you must have a border molded tray and final cast. You may scan the final cast or the final impression, but you can't border mold with intraoral scanner. And then you should have jaw recordings, and then you put all of the information to the software. It makes you, designs you a complete denture and gives you a milled complete denture for trying. After trying and changing, if there is anything necessary, you can have the denture base milled. For the dentition, you have two options: using ordinary acrylic teeth that is in the market. You have to glue them one by one to the respected area in the denture base, or you may mill all the teeth from a block, so that it all are attached to each other and make a monoblock, and then glue them all together to the denture base. So in this option, the risk of separation or detachment of the denture teeth from the denture base is not common, but because the teeth are from a monochrome material. It is not as aesthetic as the denture teeth that we have in the market. For the removal partial denture, we also should do the preliminary impression, primary survey, treatment planning, preparation of teeth, and then for final impression, if we don't need any border molding, like Kennedy Class 3 jaws, we can use intraoral scanners. But if we have to do border moldings in distal extension cases, we should scan the final impression or the cast. We can't use intraoral scanners. Then we can put the data in the software, and the software does final survey for us, relief and blockout, designing the RPD, and the design RPD will be printed by 3D printing from wax or acrylic resin, and it is cast and trying the framework, jaw recording, setting the teeth is done as usual. But now for fixed dental prostheses. Here, again, we start with a thorough examination. Now the occlusion is much more important for us because premature contacts, interferences, bruxism, clenching can actually fail our treatment. So we should have a very good examination. Then a diagnosis, and now for treatment planning. Because CAD/CAM dentistry is very now is very common in fixed dental prostheses, you may want to use something like full ceramic restorations that are made from by CAD/CAM. You should have in mind, if you want to use CAD/CAM for making your prostheses, a little bit, and the preparation of tooth is different. And the divergence, the convergence of the walls toward each other is more in when you are preparing for CAD/CAM restorations. Also, you shouldn't have any undercuts. You shouldn't have any sharp areas because the burst of the CAD/CAM milling machine cannot prepare that part. So in this situation, in fixed dental prostheses, if you want to use CAD/CAM technology, you should begin from tooth preparation. It is somehow different from the conventional methods. Impression taking could be with intraoral scanners. Of course, then you have two sides of the jaw. The bridge passes from one side to the other side. Lab scanning is better than intraoral scanning. Laboratory procedures can be done completely by CAD/CAM technology in most of the cases. There are different CAD/CAM dental materials. Some of them are fully feldspathic, some of them are lithium disilicates, zirconias, zirconia reinforced lithium silicates, and most of them are monochromatic. There are polychromatic, of course, blocks. But the point is their aesthetic is not as much as when the handmade layerings are done. So if you want the best aesthetic, it is better, it is suggested to use handmade layerings. And the infrastructure, the coping can be from these CAD/CAM materials, but it is better to layer them with feldspathic porcelain or fluoroplated as in IMAX. And we have different kinds of fixed prostheses. It could be laminates, inlays, onlays, partial coverages, full coverages, and bridges. For some of them, like inlays, onlays, and partial coverages, if you are using full ceramic materials, the only option is CAD/CAM making or heat pressing. So some of the new restorations, ceramic inlay and onlays cannot be done with ordinary mixing feldspathic porcelain powder with liquid. It would be very hard and not feasible easily. Full coverages, of course, can be done with both techniques, but strong materials like zirconia just can be made with CAD/CAM technologies. Bridges at the back side of the mouth, at the posterior side, is better to made of zirconia, and that zirconia is just CAD/CAM made. You can't do anything in any other way. Another restoration that nowadays are very talked about is endocrowns. It helps us that when we have endodontically treated tooth, not to use the intracanal space for retention of the crown. There are different kind of, perhaps a different kind of preparation for endocrowns. One of them is like this. Almost all the crown is removed, perhaps because it already had a problem, and the retention is much gained from the pulpal chamber. I don't know how much it could be successful, but it is something that has come in the literature. The second one is when you don't remove all the tooth structure, you retain what it is possible, and but for the occlusal side, you may have to prepare all the axial surfaces. We can call them endo overlays. When you just remove the occlusal surface and you are not going to cover axial surfaces, you may have endo onlays. And these are conservative treatments rather than to make a full coverage crown and use the intracanal space. For implant supported prosthesis, as you know, we have two phases, the surgery phase and prosthetic phase. In the surgery phase, it is better to determine the position of the implant from what the prosthesis that is going to be there. It is called that it should be prosthetic driven treatment planning for implant. When you do this, and you, it means that you actually design the prosthesis that you want, and then make a surgical guide to put the implant at the correct position for that prosthetic prosthesis that you have designed. You will going to have theoretically and sometimes practically, you can use this design for making a prosthesis even before surgery, if all the surgery is fully guided and no freehand or half guided, fully guided. It means that you know how, where to put the implant, how much is its depth and its angulation and its diameter of the implant, diameter of the abutment. So you have the prosthetic, you can make the prosthetic beforehand, and then at the time of surgery, give it to the patient with a very small modifications. Now let's talk about the image when a patient that already had a prosthesis comes to us and had a problem. This kind of emergency is more complicated than the first one. And whatever we do at the first, for the first group, and thorough examination, diagnosis, and treatment planning is why it's done, because we don't want our patient to be one of the second group. It is very more difficult to know what is the problem for the patient if a patient comes to us with a problem. What is the problem? What has caused the problem? And what is the best kind of management of the problem. So for these patients, the best is to prevent to have a problem, but it is inevitable. The prosthetic emergencies that I could think of were chipping of veneer layer, fracture of framework, pain in tooth or implant, tooth or implant fracture, implant screw loosening, implant screw fracture. Veneer, porcelain or any other veneering layer, if fractures, we should know what has been the problem, why it has fractured. It has been a problem of, is it the problem of the lab? Is it our problem? We haven't seen the patient has a bruxism, a clenching habit, or it is because the patient has suddenly bited on something hard. So to prevent it from recurring, it is better to know what has been the problem. And but you imagine that in this picture, it has happened. It can be completely veneered by composite resins. Of course, you have to use hydrofluoric acid and then silane and adhesives. But in this case, in this picture at the right side, and it is quite different from the other one. It seems somehow there is neglect from us or the lab, not just patients. Why? Because we have reached to the, it seems it is not much enamel, it is somehow seems that it is dented. Now, what we should do, it is difficult to fill this gap with composites and have a nice look because the shade would be quite different. And if these 4 laminates are made by a lab, and you know the lab, you can ask your technician to remake it because they most of the time, also you may have the data of your preparation, actually your optic impression, and they can redo it with the material that they have already used and with the shade that they have you have chosen and sent to them. But if the problem mainly is removing these laminates from the attached part is not easy, and sometimes you may have change your preparation, and then you should make another impression or intraoral scanning. And
excuse me, Professor Farid, we have 10 minutes until the end of this panel. So we should have some time for the questions one of the participants have. Would you please summarize your speech for 10 minutes?
Okay. We should have a framework fracture, and it mostly happens in ceramic materials because the connector area that is needed for metals and metal ceramics is not as much as the ceramics. Don't forget, for ceramic materials, you should have the connector area. Depends on the type of the ceramic and whether you are using the bridge at the anterior or at the posterior. And the posterior side has larger connector, it should have larger connector area. So you should see the suggestion from the manufacturer of the material that you are using and design the connector as they suggest. Zirconia implant framework fractures was very common and was suggested for a while, but later the technicians who had used it encountered multiple times of framework fracture. Now it is not suggested that much, and inferior or in infrastructure of metal is more accepted right now. If you have caries under crown, you should be careful. You should always look for caries under your crown and bridge because It is not much clear. You will see it in the radiographs or when the patient comes with an abscess. So now imagine that you have such a problem. You can, like this one, you can, if it is possible like this to do direct restoration, do this. But if it is somewhere that you can do direct restoration, you can remove the crown and fill this, treat this area, even if you need to do treatment, endodontic therapy, and then you can ask your lab to give a crown to you after scanning the impression or intraoral scanning. And then if you have a chairside milling machine, that you can do it by yourself, endocrown, crown, or something like this. What about a fracture of the tooth? You can now, if you have a crown in the mouth of the patient and it is painful, is it the problem is a fracture or not? By a simple test, you ask the patient to bite on something hard at that area. If the patient, when closes, there is no pain, and when opens, there's pain, it is a sign of root fracture. What we can do after extracting, it is possible to use, again, new technologies to do immediate placement and implant placement and immediate provisional restoration, delivering to the patient. Of course, not always possible. It depends on how much margin marginal soft tissue is damaged or traumatized. It must be much traumatized. In this case, is a report of making provisional restoration immediately after implant placement. Now, pain around implants. It could be because of mucositis around implant or pre-implantitis. First of all these conditions should be actually cured or treated. And then after that, if you still have the implant inside, and some, because we are playing because due to the extra cement and that it has made pre-implantitis, it is better to make a custom abutment by CAD/CAM technology and a screw retain processes for the patient. Of course, for that you should have a scan body to scan for the implant. The other problem is a screw loosening. For the screw loosening, you know that the prosthesis is attached to the implant, whether it is it is a cemented or a screw retain. The connection is by a screw, so we have a screw loosening, and a screw loosening is something that is not good for us. Actually, if you have a screw hole here, you can retighten it. But if you have a cemented crown over that, and cemented crown is completely attached to the abutment bottom, and the abutment is loosened and not the screw is not tightly at its position, you may have to remove the crown, sectioning it and removing it, and then tightening the screw and the abutment. In these cases, also you can use actually new technologies for giving the patient the crown that could be put on the this implant, and it can be done in a very short period of time. Now, a screw fracture. If you see a screw fracture, if you can remove the screw, you can put the scan body and again scanning and sending it to the lab, making designing a new processes and giving to the patient. The problem is if it is possible to remove the fractured screw, that it is the most important part. So thank you for your attention. I'm in your service.
Thank you, Professor Dr. Farid, for your presentation. And you mentioned to the emergency cases, especially about the screw loosening and the other cases like cracked tooth syndrome. I appreciate you present these cases and you informed us about this condition. One of the one of the participants has asked about CAD/CAM. Let me read the question and kindly ask the question of the participant. The question is that about the CAD/CAM machines, because this participant has asked that whether CAD/CAM machine can be used for measuring the density of the bone or not, and I answered to the guy that no, the CAD/CAM machine is for preparing the restoration, or as he mentions, for ortho or surgical guide. But another question has been presented by this participant, and the question is that how about 3D CT scan? What parameter can be observed and measured by 3D CT scan? That whether CAD/CAM machine, the 3D CT scan can be used by using CAD/CAM machine or not?
Yes, we have CTs, CBCTs for measuring the quality and quantity of bone, for forming the, actually our prosthesis, designing our prosthesis. We merge the STL files to the DICOM files and use it. STL files are files from our CAD/CAM. DICOM files are from CBCT. We merge them and design the processes that we want on the CAD/CAM, so we can have immediate implant processes to give to the patient with this technique.
Okay, thank you. There is another question, Dr. Farid, and the question is that how important is material selection to avoid or minimizing a screw loosening or a screw fracture? Would you please answer this question?
It is difficult to say what material makes more screw loosening. We know that screw loosening mostly is because of actually lower number of implants that it should be cantilevers and something like this. It means it is more mechanical than the material dependent. But we know that acrylic resins actually absorb more stress than the some tougher materials like ceramics. So perhaps with acrylic resin, it is less screw loosening.
So the answer would be the reason for the screw loosening would be more dependent on the designing of the treatment or prosthesis and less dependent on the material. But if the material, if you want to talk about the material, those type of prostheses that are acrylic rather than, for example, bridges, this screw loosening may less occur. Is it right?
Yeah.
Okay, thank you. Is any other questions for the participant? Apparently...
Yes, I would like to ask a question.
Yes, please, Dr. Khan.
Me again.
Well done, please.
Thank you, Dr. Farid, for your nice presentation. I would like to learn, you know, the CAD/CAM technology offers us 3D printing. Do you prefer or use in your clinical procedures, or what do you think about this system?
You know, we use 3D printing here for making provisional restorations. Sometimes we use it for night guards, but it is a soft one, not a hard one. So I don't suggest it for the nighttime bite guards made from 3D printers. And the materials for 3D printing are in progress. In the past, they have less stability. Now, there are acrylic resins that are 3D printed and are good as in term of stability. Do not have much changes during time. Now they are getting better. Everything in new technology is getting better in comparison with the past, and it still is going on. But I think it is now we have good opportunity to use them like for provisionals in office provisionals. It's very helpful.
Yes, thank you. And I have another.
I don't know. I answered your question or not?
Yes, yes.
Yeah,
Thank
right.
you. I would like to learn your opinion about the accuracy of the intraoral scanners. Do you use it in your routine clinical procedures, or you still prefer sometimes the conventional impressions?
I think our conventional way of life was good. I don't think that we have done something less than what we should do for our patients. But intraoral scanners, the accuracy is perhaps it is not much much it should be for when you have to scan around the arch. So still we have to use conventional impression making. And but it can be very helpful when you have a single crown or a short span bridge. It can be very helpful if you have this much these cases. For complicated cases and cases that we have to change the bite and something like that, I think conventional ways are still better.
You say it depends on the crown number or the crown area or the complexity of the case.
Yeah, exactly. And the accuracy of the intraoral scanners are getting better as, in comparison when they were introduced to the dentistry. But still, I think for the complicated cases, it's better to have lab scanning than
intraoral. It should get better. Thank you.
Thank you so much.
Thank you, Professor Kayahan, for interesting the subject that you asked some question. Again, I'm thankful to you to joining us and accompany us in holding this program. And I hope that we have next sessions, next appointment, next meeting between Tehran University of Medical Science and Yeditepe University as soon as possible. And after that, face-to-face meeting in Tehran or in Turkey. And this session, this panel was very useful for me. And I learned many things from your speakers. Thank you for the speakers that you had. And thank you to you to moderate this panel. And if there is any question, please let us know. Otherwise, we should start the next panel that is for the surgical department.
Thank you. It's my pleasure. I hope to see you face-to-face in Tehran or in Istanbul. I don't know any other question.
Thank you.
Thank you.
Thank you. Thank you, Dr. Kayahan. Thank you, Dr. Farid, for presentation. Wish the best and safety for all the participants for all the times. And I hope that this COVID-19 vanish as soon as possible. Bye-bye, everybody. I hope to see you again in near future. Bye-bye.